Good morning, and thank you for joining us today for our webinar, Improve the Value of Healthcare in Wisconsin, Avoid Low-Value Care. I'm Jennifer Austin. I am the Senior Director of Marketing and Employer Engagement here at the Alliance. I'm also a member of the Wisconsin Health Information Low Value Task Force, so I'm speaking to you as both. We're here today because we know that keeping our employees well is very important. They're our most valuable asset. But how do we know we're paying for the right kind of care? That's what we hope to talk about in today's webinar. But first, a few housekeeping items. You'll be muted during today's webinar, but please know we do want to hear from you. If you have any questions or need technical assistance, please use the chat feature in GoToWebinar and someone from our team will get back to you. In addition, we've developed some handouts based on the information from the WEO report and today's presentation. Those are available in the handout section in GoToWebinar as well. And because we're often asked the question during our webinars, this will be recorded and we're happy to share it with you afterwards. We'll send an email to attendees and it will be available on our website about a week after we're done. And just a thank you to our sponsors, Delta Dental and National Cooperative RX. Your year-long support helps us provide this great programming to employers, so we greatly appreciate it. I also want to thank Jeremy Ott, Vice President of Health Insurance Economics at WPS, for joining me today. Jeremy will be coming on just a little bit later. Both of us were members of the WEO Low Value Care Task Force Committee. And we're here to present the findings of the report that came out at the end of August. But we know that the great work that was done today that we'll be presenting on wasn't done by the WEO alone. We wanted to call attention to the fact that this was a multidisciplinary stakeholder group, both the task force and the committee made up of providers, health insurance companies, third-party administrators, networks like the Alliance, just a whole host of business groups and consumer organizations trying to figure out how to solve this issue. It first started with some funding from DBID. Analysis was done on not only Wisconsin, but 3 other states to evaluate whether low-value care existed in Wisconsin and to what extent. From there, a task force was created to review those results and determine what next steps would mean. And then the committee, which included Jeremy and myself, came together to figure out how we educate stakeholders. And a lot of this work was done also with funding from the Advancing a Healthier Wisconsin Endowment. So that was great. The Wisconsin Health Information Organization, or WEO, we thought it was important to just kind of define who they are and what they did because not everyone might be familiar with them. WEO is an all-payer claims database. So any organizations that are willing to submit their medical claims data, their pharmacy benefits information, and their provider files will then be able to submit data into this database, this all-payer claims database, that multiple organizations can access to evaluate the care that's being provided in Wisconsin. This includes commercial health plans, self-funded insurance, Medicaid, and Medicare Advantage plans. And we actually at the Alliance use this information to not only validate some of our analysis that we do, but also to supplement some of the information we have so we can provide that greater level of insight to our employers on what care is being delivered. So when it comes to data, it just made sense that WEO was the group that DBID reached out to try and do this analysis, given the fact that their information covers the majority of Wisconsin. So what is low value care? Jeremy will go into this in the report in more detail, but at a very high level, care is quality correlated to cost. Quality is one of those difficult metrics. So we've used the definition from the Institute of Medicine, which defines it as patient-centered, timely, efficient, equitable, safe. We know that it's important to have high value care. At the Alliance, we're regularly talking about how we drive more high value care. And we'll also get into that a little bit later today in regards to how we can steer to the right people. We know that high value healthcare is very important. It improves health outcomes and includes things like immunizations and chronic disease management. And low value care is really its opposite. It's not supported by research. It's not improving healthcare outcomes. It can be duplicative and it may cause harm. The goal is really to figure out, can we shift low value care to high value care or remove it from the system entirely? We know employers are paying a lot for healthcare prices. We know that physicians are burning out, and we're trying to figure out how to help this issue. We hope by educating stakeholders we'll be able to do that. There are a lot of hidden costs to low value care, things that people might not necessarily think about. It's things like poor use of staff time. Our providers are burning out. They're working very long hours. How do we make sure that they're spending their time and energy on the care that makes the most difference? And that includes duplicative and unneeded services. So maybe an MRI was gotten somewhere else. Can we make sure that we're utilizing that instead of ordering more, which requires more follow-up? Not only is it difficult for providers, but individuals have lost personal time and work time by trying to get to more appointments that may not be needed. And if those tests come back as inconclusive and require more follow-up, that can lead to emotional, physical stress that maybe wasn't even a worry, and higher insurance premiums for employers, or for self-funded employers, more out-of-pocket spend in regards to medical claims. And all of that leads to added costs for travel and childcare. And we know that there are inequities in healthcare, and this hits some of our most vulnerable populations. But honestly, we can see this across the spectrum. You might be wondering why the Alliance and WPS are involved in this effort. Well, it's a lot of the things that I just talked about on the last slide, but when it comes to the Alliance and WPS, our shared values are to make healthcare more accessible and affordable for employees. So we want to make sure that the care that we're providing, that our employers are providing, is the right kind of care. That has a significant financial impact on employers and their employees and families. We also know that we couldn't exist without the healthcare ecosystem. We want to make sure that physicians aren't burning out, that there aren't lengthy wait times, that people are able to get the care they need when they need it. And again, I mentioned shifting more care from low value to high value. At the end of the day, we're all in this together. Physicians alone can't do it. We need to make sure that employees are asking the right questions and involved in the right discussions to make the best decisions for their care, because we really do believe we're all in this together. So I'm now going to ask Jeremy to come on to talk about the research and what the end results are for employers and employees. Thank you, Jeremy, for joining us today.
Yeah, thank you so much, Jennifer. Thank you for the Alliance for hosting this event and having me be part of it. And thank you for everybody that's joining us today. I get the pleasure of sharing with you some of the results from the study. But before we get into that, on the next slide, we'll talk about some of the things, some background on the study itself, just so everybody's aware of what was utilized. So as part of the study, we had utilized the information that was available through the WEO database. And just for background, that includes claims information on about 2.8 million Wisconsin residents. In the course of time we were looking at doing the evaluation was from 2017 to 2020. So we looked at 4 years of data. And what we did with that data is we ran it through the Milliman Med Insight Health Waste Calculator. And for people that may not be familiar with that tool, it's simply a software that will help identify and quantify low value care in the healthcare system. As part of that, running it through the Milliman Med Insight Health Waste Calculator, we had identified 48 measures that we were trying to have that tool quantify for us. And I want to be clear, the 48 measures that we utilized were not things that WEO came up as commonly low value services, or it wasn't something as the committee we had developed. We used well-known national organizations like Choosing Wisely and the United States Preventative Services Task Force and utilized their recommendations on low value care. And just for people that may not be familiar with those two organizations, I just want to spend a second to talk about each of them. First, Choosing Wisely. If people haven't gone out to their website, which is choosingwisely.org, I would highly recommend going out there and using it as a reference to utilize, maybe educate yourself, educate your employees on by seeking high value care. The Choose Wisely organization was initiated by the American Board of Internal Medicine, and it was an initiative to promote conversations between clinicians and patients by helping patients choose care that is supported by evidence, not duplicative, free from harm, and truly necessary. The other organization is the United States Preventative Task Force. Now, most of you probably have heard of that organization through the ACA. They're the organization that sets the preventative services that need to be covered at 100% to be an ACA compliant plan. But that organization has actually been around for over 40 years. And it is an independent voluntary panel of national experts that are experts on both preventative services and evidence-based medicine. So we utilize those two organizations to help us identify the 48 measures that would be deemed as low value care. However, I do want to point out there are some limitations to our study that we want to acknowledge on the front end. The study that we did only included information from WIO. So while it had 2.8 million people, it was not all inclusive of all care that was rendered inside the state of Wisconsin. And the other thing is we're only using the claims data. We don't have access to the medical records. So while that's one of the reasons why there's only 48 measures, these 48 measures are typically ones that are identified as always being low value care. But there may have been other measures that may be low value care depending on the medical situation that a specific patient's in. We did not include any of those situations in our analysis for the low value care. And the last thing to point out is that claims that were not covered by insurance are not in the WIO database. So there could have been situations where a health plan or a group insurance may not have covered a low value care and that service was denied, whether it be for not being medically necessary or just not a covered benefit. That would have not have been included in our analysis as well. So when you look at the things that were not included, the actual impact is probably much higher than what we're actually going to show as part of this study going forward. So on the next page, we actually get into some of the results for the state of Wisconsin. So in the state of Wisconsin, it's estimated that $129 million was spent on low value services, which comes out to about $117 per person per year, which is on par with what we saw with the other states that were reviewed. And while those numbers, like $117 per person per year, may not seem like a lot, it does account for about 2.5% of the total medical spend in the given year. So I know a lot of employers right now are probably doing their budgeting for 2024 and what their healthcare costs might be. I think everybody would be appreciative if they're able to find an extra 2.5% that they could save on their healthcare costs for next year. So it does add up over the course of time. And like I stated on the previous slide, that probably is a much over or understated number that when we looked at the total impact of low value care. The other thing that we identified was that approximately 1 out of every 3 people received 1 or more low value services during the time period that we had evaluated. One of the things that we did not include in this presentation, but I think it's important to talk about is we also looked at the data broken down by socioeconomic factors. We put people into groups based on the information we had available, and it was important to know that low value care impacted everybody across the entire socioeconomic spectrum. So one of the interesting things was it was almost uniform across the board in each of the different categories we looked at. However, we did see slight elevations on the high end and on the low end of the spectrum for that, but just very minimal variations from that. So it is a situation that is impacting everybody across the board, the impacts on the low value care. One of the things that we really found interesting is the last item that's bolded down below. I think we would think as time went by that providers would become more efficient and that you'd expect to see low value care and low value services decrease over the course of time. And actually what we identified was the exact opposite. We actually saw that low value care services were increasing from 2017 to 2019 by 11% over that course in time. Now, for the points of full disclosure, we did see a significant drop in 2020 of low value care services, but I think it's a fair hypothesis to assume that that probably had much more to do with the COVID-19 pandemic than it did to any material changes to processes or the reduction in underlying low value care services that were provided. So on the next page, I'm going to talk a little bit about those 48 measures of low value care. And on the screen, we have them all listed here, and you'll be able to see this later. I'm not going to go through every single one of them that are on here, but I think it's important to know that they're typically all bucketed into three big categories. The first one being treatments, the second one being screenings and diagnostic testing, and the other one being preoperative evaluation. And I am going to give an example in each of the different buckets, which I think will help you understand the types of things that we're talking about when we're looking at low value care. So the first one under treatments, this is something that probably everybody has heard about with the opioid pandemic that has happened over the last couple years. But opioids that are utilized in acute disabling low back pain. According to Choose Wisely, early opioid prescription is associated with things such as longer disability stays for members that are using opioids, increased surgical rates. So somebody that has this as their treatment plan are more likely to get surgery than somebody who doesn't. And then the obvious one here is higher rates of opioid addiction afterwards. And ultimately in this situation, probably could cause more harm to the patient than the benefits by giving them the opioids for the low back pain. The second one is in the screenings and diagnostic testing, the example being an annual resting EKG. So there is little medical evidence that has a correlation to that this test improves health outcomes, and actually it has quite the opposite effect. A lot of times there are false positive tests that are likely to lead to harmful and unnecessarily procedures or overtreatment and misdiagnosis. So the potential harms of this routine annual exam is expected to exceed the potential benefit as part of this. So obviously the low value care is having an impact both on the patient being misdiagnosed and the additional care that they would seek. Under the preoperative evaluation, the example here is preoperative baseline laboratory studies. These are routine tests that are done before an operation, and there's no medical evidence that supports that these tests improve the outcomes of the surgeries. If anything, there's more evidence that what it does is it actually increases anxiety in the patients and also causes a delay in members being able to get access to their surgery. And then ultimately it's just seen as an unnecessary expense and really provides no value to the underlying care that patient ultimately gets. So on the next slide, I want to talk a little bit about and show some of the data broken down by the different provider systems that we had. And so the chart on the right shows the variances based on 25 provider organizations and how they measured for low value service. I think a couple important things to note here is that there is no provider out there that is perfect at this. Every provider we looked at has some variation of low value care services that they are providing as part of their care. Some are doing it much better than others. You can see there's quite a large range, ranging from about $100 per person to on the high end we had one extreme outlier that was at about $1,700 per person as part of this care. But most of the providers are fairly closely bunched together at around $100 to $200 per person. Now, I'm guessing some of you on the call are wishing that instead of having some de-identified information on the right hand with part of that, we would actually listed the provider systems and called them out. It was a strategic decision by the committee to not do that. And the rationale behind that was we really want this to be a collaborative effort between payers, employers, members, and providers to try to address this problem. And our thought process was that by identifying these providers or calling them out, that they would be more likely to be defensive rather than show a willingness to work with us to try to address this issue going forward. The other reason why we didn't want to list the providers, Jennifer showed earlier that there are a number of providers that were part of this work team. I wanted to be very complimentary of the providers that were part of this team. Every single one of them had verbalized their commitment to try to address this problem within their organizations. And I appreciate their efforts and the things that they're taking back to their teams and the things that they're going to work on. Unfortunately, they did share, with these provider organizations, it's likely not something that they can change overnight. But I think over the course of time, if we can continue to work with them and continue to push for changes, that will help them try to address the problem going forward. On the next slide, wanted to show an example of the variations that we see. And so what this slide shows is we took just one example of the low value care services that I had talked about before. And what we utilized here was the preoperative lab testing. One thing that I want to point out on the graph on the right, the numbers that are in the graph really don't represent anything. If you read the full report, it actually links to a list of all the counties and it includes the actual dollar amounts. The important part in the graph is the shade of color in them. The green are counties where fewer preoperative lab testing and the cost associated with them are lower. The darker the blue, the higher the preoperative testing costs were associated with those counties. So just to give you an example of kind of the range that we saw, Menominee County, I actually saw the lowest preoperative testing cost at about $18 per person per year, while Grant County was on the extreme high end at around $158 per person per year. For people like me that might be local to the Dane County market, they were kind of right in the middle. Dane County averaged about $48 per person per year in additional preoperative lab testing. And the additional cost is typically due to more tests being requested or being part of any kind of preoperative procedures associated with that. So the next slide, we wanted to talk a little bit about how can you use this information and how can you make it valuable going forward. The first part of this is employers can work with advisors to enact benefit plans that drive high value care. And Jennifer talked a little bit about this, but both the Alliance and WPS and a lot of brokers and agents out there are really trying to drive members and employers to seek out high value care. So work with your partners to try to identify ways to incentivize utilization to high value care. And we'll talk a little bit more about that in a couple slides on things that you can do and things to consider. The biggest thing, and I'll fully admit this is probably the most challenging piece of any of this, is educating your employees and their family members about the hidden cost of care. And it's not just the hidden cost, but it's also the impacts it could have on your own health. We have to get better at having our insureds be better consumers of healthcare, and that includes a better understanding of why they're getting the care they do. A lot of people are just used to doing whatever their physician or whatever their healthcare provider asks them to do. We have to get our members to feel comfortable to ask them, why do I need that service? Why do I need to have that done? And if it's just that the provider needs to check a box and it's not really going to help, the future downstream care for that individual, it's probably just at an additional cost either to the health plan or to the member in their additional out-of-pockets. And with the growing medical debt that people are seeing, I think anything we can do to help limit the exposure to the member would be beneficial to everybody involved in the process. The other thing we need to work on is helping members have more shared decision making. Customers can learn about low value services and talk to their healthcare clinicians about their goals to minimize the low value care that they seek. So the more that they're seen as being a part of that decision on what the treatment plan is, specifically, I think back to the opioid example I made, make sure that they fully understand what all their options are and what the downstream impacts are associated with that. The more they can be engaged with the provider in those conversations are only going to help the patients and lower the implications of the low value care. For the provider partners of ours that are on this call as well, I mean, provider organization clinicians can redesign processes to lower low value services and be purposeful in their clinical orders. Make sure that the things that you need are truly things that are wanted or that are needed to help further the care of the patient, and making sure that what we're requesting is truly needed. And last but not least, all of us can help by getting an increased knowledge base with our legislators. Excuse me, letting them know the importance of this topic, and making sure that they can help us try to address this as well as we go forward. Anyone that's interested in more information on this study, I would encourage you to reach out directly to WEO. Their contact information is included here, including an email address as well as a phone number. I would also be interested, anybody that would like to know more about this study and like to talk about it, I am happy to have additional conversations with you. And I don't want to speak for Jennifer, but I'm sure the Alliance would love to hear from you as well and help address any questions or provide you any additional insight or information you'd be interested in as part of this study. I alluded to this a little bit earlier, but there are some things that we wanted to highlight that you can be doing proactively as an employer to try to help address some of this low value care services. And one of them that's pretty obvious is a transformation to look at partnering with providers that are open to bundled payments. And for people that may not be familiar with bundled payments, it's pretty straightforward. It's really lumping together and having a fixed price for an entire episode of care, rather than the traditional model, which is really a traditional fee-for-service model, where the more kind of widgets and the more procedures you incur, the more your costs are. The bundled payment is just a fixed price for that entire episode. So the more we're able to work with providers to get these episodes of care, it really entices them to eliminate the low value care, because if they're paying a fixed price for the entire episode of care, there's no incentive for them to be doing these low value services. And actually, that's why a lot of these providers that entertain bundled payments are ones that have been able to take the low value care out of the system, and they know they can do it more efficiently and typically at a much higher quality than some of the others. So if you're not already engaged or looking at bundles for your health plan, I would encourage you to work with that. I know the Alliance has done a lot of work in this regard, and something they continue to work on to expand the bundles that they have available to their employers as part of their offering to self-funded employers. The other thing, bundles by themselves though typically aren't enough. You'd want to offer some kind of a bundled payment or as part of an underlying steerage incentive to members. Both WPS and the Alliance are big proponents of underlying steerage to high value. We need to help members by helping them identify high value providers. And so the more we're able to do from a steerage perspective, going back to the bundles example, if we can make it cost less for that employer to seek that high value bundle or for that service or other services, it's a win-win for everyone. It typically means it's less out of pocket for the member. It's typically less cost to the health plan going forward. And when we look at this, employers on average, if they were successful in guiding employees, could save on average about 20% per member per month over employers that did not. So there are tremendous savings that we can see as part of this, and there's a lot more we could talk about in regards to the steerage other than just the bundles part of that. It is much a larger conversation, but I think it's a great start for employers if you haven't already looked at that as an initiative going forward. So with that, I think I'm turning it back over to Jennifer for questions.
Yes, thank you. We have gotten a number of questions coming in. So I'm going to start with a question from Shelley. She asks, what are the most commonly performed low-value procedures and services? I think we kind of talked about that. And how can my plan engage both providers and members in order to discourage the use of them, except when they're appropriate? Do you want to start and I can jump in?
Yeah, I think that answer is a little bit different depending on what you're representing. So I'll first start that through the lens of the payer, right? So whether it's WPS, whether it's the Alliance, whether it's a different health plan or a different network that's out there, I think the more that we're out there talking to our providers about low value care and stressing the importance to us about the low value care, I think it'll just help keep it top of mind and help us move some of these initiatives forward. I think it's challenging if it's just one of us out there in the marketplace talking to a provider, and it might be important to us, but if they don't think it's important to anybody else, I don't think it will gain as much momentum as it would be if we had a collective effort of all working together in doing that. From the member perspective, like I said before, the most important part, and I understand it's probably the most challenging part, it's education. We have to do a better job of giving our members, our insureds, access to information to help them be a better consumer. We all on this call know healthcare is very complicated. There's no way around that, and I'm not going to say that we're going to be able to get to a point where we're going to make it simple, but we at least have to give them the resources to be able to ask the right questions. And I think that's where it all starts, is being able to ask the right questions and being able to educate themselves on the services. And I'm going to highlight the Alliance is going to share a great piece that they put together here in a little bit that I think will help with some of that. But I think that's just a start. I referenced earlier Choosing Wisely website. I would highly recommend spending some time out there, making sure your employees know that that's available to them, because I think that is a great resource as well.
I agree. We've got more questions about engagement coming in. So how can I help employees become more engaged in their health and decision making? And what's the best way to communicate to employees the use of high value providers? How can I incentivize positive behavior? I've kind of lumped a couple of questions together here, but I'll start. And Jeremy, if you want to jump in, just let me know. I think Jeremy already touched on this. Communication and education is key. Just making sure that we're in front of employees at the beginning of the plan year, but not just then, that we're regularly communicating with them so that we can try and get in front of them when they're about to make decisions. We already talked about the handout a little bit, but I think it helps patients think through, do I need this and how do I ask it appropriately? Because we want to be mindful. It is kind of difficult to advocate for yourself in that setting. I know I've asked the question before, like, does this change my treatment plan if I do this thing? Well, it's good to know. Well, do we need to know it then? I think it's hard to push back because you also want to make sure you're as healthy as possible. And maybe you do need that test and you don't know, but I think it's fair to ask the question. So making sure that you're communicating upfront and often. I think communicating in multiple different channels is important as well. As a marketer, I always think about not everyone consumes information in the same way. So do I have it on a website? Do I have it on an internet? Do I send emails? Do I have flyers in the break room? I think while they all may seem like little things, the more we can be in front of people when they're trying to make those decisions, the better the outcome will be. And then making sure they have the right tools. So our Find a Doc, for example, is integrated with WPS for a number of our plans. Like, do they know where to find, the doctors that are in network and the doctors that are at different tiers? Jeremy touched on steerage a little bit. I do think that's kind of the incentive that we're looking at is, and WPS does this as well. Can we provide $0 care for those services that make the most sense? Not all employers can afford to do that or want to do that, but I think it offers up the opportunity for employees to feel like they can get their care taken care of, but not for maybe things that don't make sense. So Jeremy, anything you want to add on that?
No, I think you did a great job. The one thing I would just emphasize that you hit on is from the communication standpoint, it can't be a one-time communication thing. I think too often we spend a lot of time and energy at open enrollment and making sure we educate all of our members and all of our employees on all the great benefits that they have. And then throughout the year, probably not as much. But I think it's important as throughout the year, because people don't need these resources until they need them, right? And so making sure that stays top of mind, and there's different ways to do that. And I agree with the multi-channel. You know your employees better than I do, and how to best reach them as part of that. But I just think that's the part that I would emphasize is just, you can't have this be a one time a year conversation that you're having with your employees. It's got to be something that stays at the top of mind.
Great. We have a question here about where can an employee receive better information on quality of care and providers? I need something that's easy to navigate. I will be honest, this is a tough one. We already kind of alluded to it. Quality is difficult to measure. Do you have anything, any guidance you can provide on this one, Jeremy?
Yeah, I think that's the question that's a challenge for all of us, and it's a challenge for a lot of different reasons, right? And I think it starts with the definition of quality itself. You could ask 10 different people in the health and healthcare space and get 10 very different definitions on what they define as quality in healthcare. And I think for the purpose of this discussion, we were talking about high value simply being a cost and quality equation. Well, I would articulate, based on what we just talked about with low value care, there's also got to be an appropriateness variable associated with quality of care, right? And that gets really challenging to try to quantify. So I guess I would put it, I know both WPS and the Alliance have initiatives and efforts to try to get better at this. And I'm hoping in the coming months or year that we will be able to have another one of these webinars and talk about some of the great advancements we made at that. But I don't have a great reference right now that I would tell you is the be all end all for quality.
Yeah, we would agree. And we do have Leapfrog, for example, incorporated into our Find a Doc, but we know that's just one little thing where we're, as you said, Jeremy, trying to figure out how we can incorporate more. But there's a lot of work to do, not just from our end or your end, but working with providers and trying to get transparent information so we understand what that quality means when we include it. I'm getting a lot of questions about naming the provider that was the outlier. We did think that might happen. I'm just gonna answer for Jeremy and he can chime in. The intent right now is not to name that provider. I think this is something we're trying to think about. Can the Alliance incorporate this as, for example, a measure that we could include in some of our analysis? I don't know the answer yet. I know our analytics team hasn't dug into this super deeply. So I'm going to say not right now, unless you have a better answer for me, Jeremy.
No, I mean, I would agree with that. And that's why I tried to address it up front on why we didn't display the actual names. I think the goal is that by not showing them and just showing that nobody's perfect in the space. We can all make improvements that hopefully that will get attention and we'll be able to work with these and they take it serious. I guess it's not my call whether the stuff would get released. I think though that if things didn't improve and there are still challenges, I'm not going to say that wouldn't change. It could potentially change. That's would probably be somebody else's decision as part of that. But we really want this to be a collaborative effort across the different stakeholders as our first objective to try to address this problem. And the first part of that is acknowledgement that there is a problem. And we have gotten acknowledgement from the providers that were participating in this, that this is a problem and that it needs to be addressed. I think if they would have been looking at it the other way, where they didn't view it as a problem, or it wasn't something that they were willing to push back, it might have been different.
Yeah, and I know we had a few chief medical officers included as part of this discussion. We talked about what they could do from a process standpoint on their end, but as Jeremy said, it's just not an easy solve for anyone, which is why we're here to try and figure out how we can bring all of us together to try and solve this. We have another question about how can employees and patients avoid low value care? How can I identify some of the providers in our community doing it the most? So another question, trying to call out providers. We appreciate your enthusiasm. We'll figure out how to incorporate this into our data and analytics in the future. I know we already do include something regarding resource utilization and making sure it's appropriateness of care. I think we already talked about how to educate employees about what services they might ask questions about in the handout. So the hope is that that will be beneficial to you all. The other thing I want to keep in mind is that we do have preferred value providers that I know WPS uses as well. So we can help. I think this comes back to steerage again and education. But is there anything you want to call out on that, Jeremy?
No, I would just re-emphasize what I said before. I think there's some power in asking the question why. Why are you recommending this this service to be performed? Why is it, what impact is it going to have on my future healthcare plan? And unfortunately, I think a lot of the times you'll get the answer of, well, we just have to check this box before we can get to the next level. And to me, that's not an acceptable answer, right? If it's not going to impact my care going forward or give a definitive direction on where we should go, then the service probably shouldn't be provided. And we gave the example of the preoperative testing as an example, because that is one of the biggest ones that we see as a low value care services that's performed. And the research shows that there is no value by having that baseline. There's very little evidence, if any, that it improves outcomes at all. And like I said, it actually delays services, and it uses up resources in the system that could be utilized to do other things, some more high value care as part of that. And so with the shortages that they have on nursing staffs and just providers in general, it's just not a good use of resources. So there is some power in the asking the why and becoming a good consumer and trying to push back and understand.
And I do want to call out, neither Jeremy nor myself are doctors, so we are not giving you medical advice right now. Not that I needed to include that disclaimer, but the reason I do is because we have talked about preoperative testing. It's for healthy people. Let's say you have pre-existing conditions before a major surgery, there might be a need to do some of that. I don't want you all to think that this is black and white, either it's good or it's bad. It's more about, if a person is generally healthy, why are you getting that resting EKG? If a person is healthy and they don't have any comorbidities, why are you getting a bunch of preoperative tests? It's more about asking the question so that your doctor could say, well, you actually have high blood pressure and that's something we're worried about when we go into surgery. Okay, well then I understand what the rationale is, but until you ask that question, we just want to make sure they're not checking all of the boxes. We did get a question about DPC steerage that I wanted to touch on. They asked about, it was kind of a vague question, so I'm going to make an assumption, and if you would like to follow up on it, you can, person who submitted this. But the intent here is that we do work with direct primary care providers, independent primary care providers, and we provide them with a list of recommended places to steer to. That doesn't mean that's the only place they can steer to, but it's a decision point to help make sure that we're continuing to drive high value care to organizations that provide good quality care at a reasonable price. Anything you want to add on the DPC steerage route, Jeremy?
Yeah, maybe not specific to the steerage component of it, but just DPC in general, the direct primary care. I kind of consider them, even though they're technically not a bundle, I look at them much a similar way, right? So much of the DPCs are based on a monthly fee that you pay them regardless of how many services you utilize. So kind of the same concept with the bundles. They're incentivized not to have a lot of low value services or not to do those types of things. And so a lot of the people that have gone in the DPC route have done it because they didn't want to do a lot of the low value care and things associated with that. So just a different spin on the DPC, but I just wanted to call that out as well.
Great. I think you touched on this briefly, but there was a question about connecting low value care to health disparities. How does reducing low value care contribute to equity? I think we kind of touched on the fact that there's nothing super definitive in the study, but anything you want to touch on there?
No, other than the fact that the reason I brought it up was because I wanted to point out the fact that this does impact everybody. It's not like it's only on the extremes or on other side. It's pretty uniform across the boards, with just some slight outliers on the extremes on both sides of it. So I think it's an equal distributed problem that everybody is impacted, and we need to come up with a solution because it impacts everybody as part of that.
Great. I got a question about the importance of culture of company when successfully engaging and encouraging employees to participate in programs like this. I'll start and just say I think it's very important. At the Alliance, I'm lucky to work for an organization that really kind of walks the walk. So we're self-funded, we do steerage here, and we have great advocates and our senior leadership explaining, I'm going here for these services, and even kind of sharing those personal stories to make sure that we understand as employees, they're looking to do the same thing that they're asking us to do. And definitely allowed the opportunity to take the time off to need to take care of ourselves. So I would say, I think it's incredibly important for a company to be engaged from the top down to make sure that this can be a successful plan. Anything you want to add, Jeremy? I know your plan includes a lot of steering and tiering as well.
Yeah, no, I agree with everything you said. Culture does play a big part in it, and being able to get the buy-in from your people. Because let's be honest, the easy button is for patients is to do nothing, right? Just take the orders of your physician and just go through that process. And so for companies that have invested the time and the energy into education and get the employees to buy in, it's going to help with not only the steerage, but encouraging them to ask these types of questions as well. So completely agree. I think it is a big component of it, but everybody else knows their organization better and how this could best be placed within that organization.
Great. I know we have a few more questions, but we're running out of time. So I just wanted to say thank you to Jeremy. Thank you very much for taking the time to be here with me today to try and present this information. And thank you for all the great engagement we had online. We got a number of questions, and please know, just as Jeremy said, we're here to help just like WPS is. So if you have any questions, if you need additional resources, know that you can reach out to your account executive here if you work with the Alliance, or if not, you can use this QR code to reach out to our business development folks. But I think we're happy to talk more about this topic and happy to figure out how we can help employers make a difference here. Just a reminder about the handouts. I didn't go through them in depth in today's presentation, but you can request a copy by emailing the events, or you can download them from the handouts within GoToWebinar. I also just want to ask you all to take the post-event survey if you could. We do use the feedback that we get from you all to try and improve our events, so we greatly appreciate it. And finally, we have our fall symposium and annual meeting coming up in October. We hope to see you there. I just want to thank Jeremy again for joining me today. I really appreciate it. And thanks again for you all for joining us. I hope you have a great day.